Hello, my name is Dr. Don Buford, and this brief presentation is a case study on a shoulder arthroscopy case using the Trice Medical MyI2 needle arthroscopy unit. This is a disposable in-office needle arthroscopy setup that allows us to make intra-articular evaluations of the knee, shoulder, and hip. I'm also the director of the Las Vegas MSK Ultrasound and Orthobiologics course, which is another training course where we not only teach MSK ultrasound but also the Trice Medical MyI. So brief case history, this is a 26-year-old male. He had a left shoulder posterior dislocation 13 months ago after a seizure. After non-operative treatment failed, he had an open lesser tuberosity transfer procedure. This was done about 9 months ago. He now complains of pain and clicking over the anterior shoulder and really with any shoulder motion. On physical exam, he has a healed large deltopectoral incision. He has a significant Popeye muscle deformity in his biceps muscle. He has palpable anterior screw heads that are tender to palpation and tender with range of motion. We can't assess his anterior or posterior stability secondary to his discomfort. He does appear to have good strength in the rotator cuff. As part of the evaluation, we obtained some radiographs. As you can see on the upper left, he's got two 4.0 partially threaded cancellous screws in the lesser tuberosity. You can see one of the washers looks like it's not quite approximated to the screw head. And on the bottom right image, on the axillary lateral, you can see the location of those 4.0 screws. So why did we choose the MyI2 needle arthroscopy as our imaging modality? Well, number one, because of his symptoms of pain with motion, I was worried about an intra-articular source of his pain. We wanted to diagnose any ongoing intra-articular injury. An MRI scan would have had significant implant artifact from the 4.0 cancellous screws in the humeral head. And then finally, we were able to pre-certify this examination and get this done at the same initial office visit, saving the patient a lot of time and logistics in a return office visit and a separate visit to an MRI facility. How did we get it done the same day? We pre-certify all these procedures. Took about 10 minutes for this particular patient's insurance company. This procedure was covered 100%. And it was interesting because if we had done an MRI or CT scan, it would not have been covered 100%, and there would have been some charge to the patient. The in-office code for this procedure is the same established CPT code for diagnostic shoulder arthroscopy. So here's the image. We did the procedure in the seated or beach chair position, but since I operate in the lateral decubitus position, I actually rotated the MyI2 device. So this image is as if it were a lateral decubitus position. So inferior is to the left, superior is to the right. We're looking from posterior. And so at the bottom we can see the glenoid, we can see some chondral erosions. As we look up to the right, there is no biceps tendon inside the joint because he's had a failed biceps tenodesis. But we can see that the chondral surfaces are not pristine anymore. One of the diagnostic points I was trying to evaluate was the posterior labrum and posterior capsule, and I can see here that he's got a very loose posterior joint and some posterior capsular laxity. I don't see any significant loose pieces. He's got a relatively large inferior recess. Also very important, I don't see any significant bony deficiency in the posterior glenoid, which may be important if we have to stabilize his shoulder. So we learned that he doesn't have any significant bone loss from the posterior glenoid. He does have a deficient posterior labrum. There was no significant biceps stump in the joint. There were no loose bodies in the joint. He does have generalized chondral wear changes on the glenoid and humeral head. We should be able to remove the screws without difficulty, and we should be able to do an arthroscopic posterior capsulolabral reconstruction without bone augmentation if necessary. So I think this in-office needle arthroscopy was a valuable diagnostic tool in this situation. Thank you very much.